language of communication will be English, as we have honorable doctors from other countries as well. As we can see, the brachial plexus emerging from the cervical spine and then ending up in the near the shoulder in the form of nerves, nerve branches. The brachial plexus emerges as nerve roots, starting from C3, 4, 5, 6, 7, 8, T1, and then they form the trunks divisions, and then their divisions transforms into cords, and then the terminal branches. As you can see in this illustration, there are 4 figures given. The A figure, interscalene level, B is supraclavicular level, C is the infraclavicular, and D is the axillary level of the brachial plexus. If we see the figure A, interscalene level, and we see the illustration above it, we can see the shaded area is an area that is blocked by interscalene block, interscalene brachial plexus block, in which the nerve roots C5, 6, 7 are blocked. So it blocks the shoulder area mainly and the hand, but sparing the ulnar part. If we come to figure B, supraclavicular level of the brachial plexus, if it is blocked, except for the intercostobrachial nerve distribution, it blocks the whole arm, starting from the shoulder, the elbow, and the hand. It is also known as spinal anesthesia. The block of the supraclavicular is known as spinal anesthesia of the arm. In this, any surgery of the arm distal to the shoulder can be done. Now coming specifically to the supraclavicular brachial plexus block. What are its indications? Before going into anatomy and finding the landmarks, the structures, first we should know what are the indications of this block. This block can be given to the patient for anesthesia to forearm, to the wrist and hand, and if combined with the intercostobrachial nerve block, for anesthesia to elbow or for distal humerus surgery as well. It can also give analgesia to entire arm, including shoulder joint. Positioning while performing this block, the patient should be supine with head turned to contralateral side and a pillow behind thoracic spine. In second part of this session, we will be showing you how we are going to position the patient. That will be a live demonstration of the sonoanatomy, not the block. How much volume is given? 20 to 25 ml of volume is given, and it is given at 2 different locations. It can be given it is given first between the superior and middle trunk, and then but initially the 10 ml is given at the corner pocket for ulnar nerve, and the second 10 ml is given between the superior and middle trunk region, the fascia between the superior and middle trunk. Side effects include the Horner syndrome because of the spread to the cervical sympathetics, dyspnea if the spread goes to the phrenic nerve, and paresthesias if there is a needle nerve contact, and muscle weakness of arm and hand. This is very common after block, once the patient recovers from the motor block. If we see here, we can see the landmarks. The clavicle is the landmark, and the probe is present in the supraclavicular fossa. And we can see the linear position and the needle position. Needle position is for the in-plane approach for the block. And the probe is linear probe. The patient is lying in supine position with his face contralateral to the side of block. Now, if we look here, this is the colorful illustration of what we will be seeing on an ultrasound image. Ultrasound image is only black and white. But if we go through this illustration, this colorful illustration, we will come to know, we will figure out what anatomical structures we are having on the screen. The biggest landmark is the subclavian artery, and then the first rib, the pleural cavity lying below the first rib, and the nerve plexus lying in the brachial plexus sheath at 2 to 3 o'clock of the subclavian artery. And as we see there is a red dot or the red circular vessel. This is the dorsal scapular artery. Usually it is not, on color flow, it is not visible, but with negative aspiration, we have to rule out any injected into the vessel. And if we see closely to the figure, there are two needles, needle 1 and needle 2. Needle 1 is the first block that in which we are going to block the corner pocket for ulnar part. And the second needle is between the superior and middle trunk. In both the regions, we are going to give 10 ml of the local anesthetic. But before we go for the 10 ml, we will always give local anesthetic of 1 to 2 ml to see the spread, needle tape, needle location, a little hydrodissection. Now this is a little mix of the sonoanatomy and a colorful illustration. We can see the red is the subclavian artery, and to the right side of the subclavian artery is a brachial plexus sheath in which there are all the trunks and divisions. And below the subclavian artery and the brachial plexus sheath, there is a white hyperechoic or white line that is the first rib. We can see subclavian vein, anterior interscalene muscle. Now these two white lines are the needle directions, needle trajectories. This is how we are going to approach while doing the block. This is exactly the figure we are supposed to see while giving a block. And it will be only possible if we rightly keep the probe in a right position, with a patient in a supine position, a pillow under thoracic spine, and face contralateral to the block, side of block. Again, we can see the brachial plexus, the B, the R is rib, the omohyoid muscle, the O. Above that is the sternocleidomastoid. On left side of the subclavian artery is the anterior scalene, and on the right side of the brachial plexus is the middle scalene. Now, if we see this figure, we can see a needle going down. We can see the rib below, and the needle is exactly into the brachial plexus sheath, and the fluid is injected around the trunks. And we can see the subclavian artery away from the needle direction. Now this is the supraclavicular innervation with the supraclavicular nerve block. What we are going to innervate, the cutaneous innervation on the right side we can see. As we see, there is a little part missed at the axilla and the medial part of the arm that is covered by the intercostobrachial nerve block. The motor part we can see, and then the osseous part, in which the whole humerus, radius ulna, all phalanges and the scapula are covered. Okay, what are the indications? Its indications includes surgery of the forearm, the wrist, the hand, and it can be used for analgesia of the shoulder, arm, forearm, and hand. In distal humerus surgeries, in combination with the intercostobrachial nerve, anesthesia can be given. We can also use for analgesia, we can use analgesia catheters that will be giving the drug continuously. Now coming to the complications. These complications are common as for all the nerves, for all the nerve blocks, like intravascular injection, the neural injury, but specific to this block are the phrenic nerve spread that can cause dyspnea. It can cause stellate ganglion block, it can cause pneumothorax, and it can cause Horner syndrome as well, in case of the spread to the cervical sympathetics. Now, going through comparison with other blocks, we will compare supraclavicular brachial plexus block with the interscalene block. Supraclavicular brachial plexus block is done for any surgery of the arm distal to the shoulder. Its advantages are anesthesia of all portions of the arm distal to the shoulder. It has a fast onset, and it is very simple to perform with ultrasound guidance, and it is very safe with ultrasound guidance. We can avoid the pneumothorax, and we can avoid the nerve injury, and we can avoid direct entry of nerve into the vessel and giving any inadvertent intraarticular or intravascular injections. And it requires a relatively very small amount, like just the 20 to 25 ml of local anesthetic. There is in disadvantages, there is a very potent potential for pneumothorax, but with ultrasound guidance, it can be reduced. Okay, this was all about the theoretical part. We are heading towards the live demonstration in a while, but before we go there is an assessment. What structures lies lateral to medial in the ultrasound guided supraclavicular approach? Note down these questions, we'll be discussing it. Make your answer. And the answer is 4. Medial scalene, subclavian artery, and anterior scalene. This is the lateral to medial structures. Which is true regarding supraclavicular approach of brachial plexus anatomy? It blocks what? It blocks nerve. It blocks nerve roots and trunks, cords or divisions, trunks and divisions, or block trunks. It blocks trunks and divisions. Going back, the cords are blocked by the infraclavicular block. The roots are blocked by the interscalene, and the branches are blocked by the axillary brachial plexus block. What type of surgery can be performed by performing brachial plexus block using this approach? Already discussed. The drugs, what drugs we can use? In Pakistan, we are having lignocaine, we are having bupivacaine. We use combinations. And what dosage and what volume? For motor block, 0.25% or 0.5% of bupivacaine is used. Volume 10 ml, a total of 20 ml of volume is enough for the whole block. Position is the probe position and the patient position. Patient should be lying supine with his face contralateral towards this, contralateral to the side of the block, and the probe will be the linear probe, and it will be placed in the supraclavicular fossa. Needle insertion in plane or out of plane. The most preferred needle insertion is in plane, in which you can see the whole length of the needle, and most importantly, you can see the tip of the needle. Unless you see the tip of your needle, you are not supposed to give any drug, and you are not supposed to proceed the needle. You are not going to push the needle anywhere unless you confirm its tip, whether if it is in a safe position, at a safe location or not. One more thing, if you are giving any drug and there is a high pressure or high resistance while giving any injection, you simply have to withdraw your needle a little bit, as you may be into a nerve element, like direct injury or entry into the trunk or division. There are so many vascular elements near the plexus, so care is needed, like subclavian artery, subclavian vein, in dorsal scapular artery. One more thing, the upper trunk is formed by the C5 and C6 nerve roots. So in live demonstration of the sonoanatomy, we will be catching these nerve roots at interscalene spot, and we will follow them caudally up till supraclavicular fossa, where they will be forming the upper trunk. And the major landmarks are the clavicle and subclavian artery, the probe parallel to the clavicle. Okay. Which nerve is missed? The ulnar nerve can be missed when employing a supraclavicular approach to blocking the brachial plexus 30% of the time. This is why we need to inject a drug into the corner pocket first. Thank you. Now we are heading to the live demonstration on patient.
If anyone have any question, kindly write your questions in the chat box so that we can ask Dr. Jamal to answer them. Thank you so much.
It's otherwise a very easy block if you have an ultrasound machine, and it's very safe, and it gives you an awesome results. You can do all kind of arm surgeries in it.
Can I ask a question?
Ji, madam.
Sir, you mentioned that we can also go through the out-of-plane approach. So how will we avoid the neural structures to get to the corner pocket below the subclavian artery?
Okay, it's the needle direction. While using ultrasound machine, if you want to move deep, if you want to go down into the screen, you increase the angle of the needle. Is it clear? You just have to keep the needle tip in vision and keep moving.
But sir,
as you
if
see
we
the
are
whole
going out of plane, not the in-plane view.
Madam,
out
honestly,
of plane.
I do not recommend any out of plane procedure in this one. At least we are
Yes,
having a lot of structure.
that was my point, because we always do in-plane technique. I've never even attempted the out of plane. So that was just out of curiosity, that how do we approach the corner pocket, and if we go out of plane, we'll be direct hitting the neural structures then, I think. And especially for the beginners,
Easy.
I think the in-plane technique
No,
is
it's
more
easy.
easier.
It's not very recommended option, because in out of plane you seldom see the tip of the needle unless you have very good machine and a very good hand of using the ultrasound machine. But if you want to perform it, you keep moving down and you keep checking the pressure of injected. As you see, whenever you are moving while performing any block or any procedure, you keep doing hydrodissection. But whenever you feel high pressure, or you feel resistance while giving the drug, that means you are not into that means you are into something firm, and the only firm structure there are the trunks, the neural tissue, because the artery is soft, the vessels are soft, and the fascia are soft.
Yes.
So
And
you
sir,
keep
what
moving
Jamal,
down.
we have question. Dr. Jamal, we have question in the chat box. Dr. Kamal Afridi has asked the quantity of the drug, and please also tell the block sustain for how much time.
Well, if we go, the quantity of drug is not, I will advise not more than 20 ml, 10 ml at the corner pocket, and 10 ml between the upper and middle trunk. So that makes almost 20 ml. And before giving these any of this 10 ml, we always give 1 ml or 1 to 2 ml to see the needle tip and to do a little hydrodissection and to confirm the needle location. That makes almost 22 to 24 ml of drug. And how much long does it last? Like all the nerve blocks, if we perform a motor block with 0.25% bupivacaine, it is going to last for 4 to 6 hours. That's a safe time of duration.
Right.
That is common.
Right.
I
Ji,
think
sir.
Sir Amir wants to say something.
Sure, sir.
And I just endorsing your point of view regarding the time of block. Definitely depend on the combination. If you are using some adjuvants, that will increase the time duration as well. And if you are using the simple bupivacaine or ibuprofen, that will give you 1.5 hour and 2 hour dense anesthesia effect. And then after that, it will be analgesia phase, and then fade it. Okay.
Right,
Thank you
sir.
so much,
Thank you,
sir.
Dr. Amir.
This is exactly.
Uh,
Thank you so much, sir.
Dr. Amir, sorry, Dr. Jamal, we have another question. What is the depth in the plane block? What is the depth when the needle is going in the plane in the block? That is asked by from DG Khan.
Well, the depth, we do not measure it as such, like because it's not a blind procedure. We see, once you see the whole neural tissue, the whole brachial plexus sheath, you can see the tip of the needle. What deeper is the corner pocket. There you go a little deep, and for the upper and middle trunk, between the fascia, between the upper and middle trunk, that is superficial part of the block. So like what the depth should be, it's not a measurable depth. It's not a measurable depth that we have to adopt. We have to see the needle. Anatomy differs for every patient, for every individual. So you need to know how deep you are going to go. Your target, if it is achieved, you have to give the drug there. Yes, sir.
Depth is variable in every patient. It's not matter to be bothered. And his question is also about the needle size. And you can attempt this block even with 20 cc needle. In very obese person, you have to choose some long needle. Otherwise, you can attempt this block with 20 cc needle simply. No need of any specific needle.
Dr. Amir said it's 1 to 2 hours duration, and you said 4 to 6 hours duration. So it's quite controversial.
Not controversial. I said that give dense block for surgical condition, that is 1.5 to 2 hours, and analgesia effect can prolong to 4 to 5 hours even after that without any adjuvant. And if you added any adjuvant like dexmedetomidine or any opioid, that analgesic phase can be prolonged to 8 to 10 hours even.
Exactly, sir. Sir, the motor component of block will last for 1 to 2 hours or 1.5 to 2 hours, while the sensory component will last for 4 to 6 hours, or maybe prolonged if we add adjuvants to it.
Yes.
So can we increase the anesthesia effect with adjuvants?
Yes, we
Yes,
can.
definitely.
From 1 to 2 hours to how many hours?
If you have concern of for a long time, you can put the catheter there and give the top-up dose.
Okay, sir. Okay. Thank you, sir. Thank you.
No, the concern of timing or duration is not there regarding the blocks. If you have such concern, you can add adjuvants. And if you have some prolonged time expectation, then simply put the catheter and give top-up blocks.
Thank you
Sir,
so much.
someone is asking, Dr. Usman is asking about the drug combinations. Kindly, can you please enlist some of the drugs?
So there are there are 2-3 drug combinations. If we take the constant or the basic drug as bupivacaine, we can add Precedex to it, dexmedetomidine. We can add tramadol to it. We can add lignocaine with adrenaline to it to prolong the effect. Sir,
Okay, sir.
Basic
dose is 1 microgram per kg.
Like adrenaline, and even you can use that is phenylephrine as well. And other adjuvants you can use opioid. If anybody has availability of fentanyl or morphine, you can also add that opioids as well.
So what is the dose of tramadol in this?
we can safely add 100 milligram of Jamal can be added, because since it's
Yes.
around the neural tissue, so it is slowly going to create the effect and augment the effects of bupivacaine or any other local anesthetic.
So we
added as
will
a
inject
basic.
the whole ampule Jamal.
Yes, we can inject whole.
Okay, sir. Okay. And sir, basically same dose, 1 microgram per kg.
0.1.
Yes.
1 microgram?
1 microgram. 1 microgram. Okay.
1 microgram. And so fentanyl dose, sir?
Fentanyl 3 micron. You can use 3 to 5 micron.
Okay, the 3 to 5 microgram per kg. Okay, sir. Thank you.
बस इसमें ये होता है, ये जो आपके ब्लॉक्स है ना, इवन के एपिड्यूरल और स्पाइनल में आप बहुत स्पेसिफिक रहते हैं रिगार्डिंग द डोजेस, उनका इफेक्ट आपको एडवर्स इफेक्ट वहां से ज्यादा मिलते हैं। और ये जो ब्लॉक्स हैं और इवन जो फेशियल प्लेन ब्लॉक्स हैं, उसमें अगर आप डोज ज्यादा भी दे देते हैं उतना कोई मैटर नहीं करता। इवन वी हैव एक्सपीरियंस कि ये जो टॉक्सिक डोज की एक मिथ है कि 3 mg पर kg के हिसाब से अगर आप ज्यादा दे देते हैं Xylocaine या bupivacaine, I have not seen any toxicity, even हम उससे ज्यादा भी दे देते हैं।
Dr. Amir, can you kindly please repeat this all in English, because we have some participants, foreign participants here.
Regarding this dose of local anesthetic and other drugs, the concern is much less when we are injecting in blocks and facial planes. We have a very wide margin there in comparison to spinal, subarachnoid block and epidural block, and even IV. So even you can, if you have crossed the toxic dose of xylocaine or bupivacaine, in many cases I have not seen any toxicity regarding to that. This is my personal experience, but definitely have. You can.
Thank you so much, Dr. Amir, for joining us today and for answering a lot of questions.
Thank you so much, sir Amir.
Dr. Jamal, thank you so much for the very nice demonstration.
One comment. Dr. Sir, I want to one comment. Dr. Jamal is doing
Yes, sir,
wonderful
please,
job, and he is no doubt he is a wonderful teacher and very clear concept about the ultrasound and image guided interventions. I have experience to work in the same sessions in different modes, even face-to-face workshops and online. And
thank you, Dr. Jamal, for wonderful presentation.
Thank you so much, everyone. Thank you so much, Sir Amir, for your kind words. And we are here at this spot because of you and other teachers who always helped and supported us. Always looking forward for your support, sir. Thank you so much, everyone. And I want to thank all my teachers who are here with us. Thank you.